everybody, and welcome to another episode of Saturday Pharmacist with your host, Hunter Maxwell, and our reoccurring guest slash co-host, Dr. Franco. How are you doing this evening? I guess we're recording. So how are you doing today, Dr. Franco?
I know. I feel reoccurring guest and co-host. I like the multiple titles. No, everything's good. We're getting vaccines out, which is great. It's warmer outside, so hey, we got a lot of positive things going here.
Yes, the weather has been great. I've been working on the golf game a little bit, but school comes first. So, but yeah, the weather's been good and the show's been good. A lot of positive feedback. So this episode, we're going to continue from our last conversation about the opioid epidemic. So briefly, last time, I guess 2 weeks ago, we mentioned COVID and how it's impacted us mentally and with the people who are, on these medications and how it hasn't, the addiction to them has led to something quite severe, more than it has been in the past. So we want to bring light to that in a good way and mention some good ways how we can combat those issues this week. We also talked about the origin and the timeline. So if you need a refresher, you can go back to episode 2 and check that out. Is there anything else you wanted to mention from last week before we get into the show?
Yeah, I think the things that really we heard some nice feedback on was our discussion on marketing, the marketing practices that many pharmaceutical companies were using during the late 90s and into the early 2000s around medications for opioid pain medication. And is it ethical or was it not ethical, especially as we relate it to the way certain social media companies, Facebook, Twitter, how they handle some of their marketing and the utility of our data. So I think that some of the stuff that we're going to talk about today is going to harken back to that a little bit and kind of give us an opportunity to revisit it and say, like, all right, with everything that's supposed to go on, is it going to be viewed in a negative light because of the bad taste people have from the shady marketing practices of the past?
Right. There was a lot of food for thought last episode, with the plush toys handed out and, I mentioned golf. So like the golf balls they're handed out. So the marketing, was it ethical? We don't know. Like I said, food for thought and for other people to decide. But it's great that you bring that up because, first we're going to talk about how the U.S. Department of Health and Human Services came up with, I guess they want to say 5 major priorities for combating the crisis, as I keep mentioning. So I'll list them off and then we could discuss each one after. So we have the first one that they mentioned is improving access to treatment and recovery services. 2 would be promoting the use of overdose reversing drugs. 3 is strengthening an understanding of the epidemic through better public health surveillance. 4, providing support for cutting edge research on pain and addiction. And the 5th one they mentioned is advancing better practices for pain management. So I feel like there is a lot more than just these 5 that we can do, but it's a good start. It's a good summary. And starting with the first one with improving access to treatment and the recovery. I feel like before COVID, we did a good job with that. We got, I'll kind of sneak peek the drug we're referencing, like naloxone. And, there's a lot of recovery services out there that I know throughout my pharmacy experience through school that we get educated on. But I'm not sure that we're pushing people towards those services as best as we can.
Well, when you look at the data, so there's a national survey that goes out every year to question substance use from drugs, alcohol, smoking, mental health, and so much more. And when we look at the most recent data, we see that the number one reason people did not go to get treatment is because they didn't know where to go to get treatment. That the stigma that's associated with it actually came in second place, stigma from family, friends, employers, and so on. So while there are treatment programs available, there's a few things. We're fortunate enough to be in a slightly urban, I guess you could call Wilkes-Barre slightly urban. We're not Philly or Pittsburgh, but we're not necessarily a highly rural area. In more rural parts of the state and certainly more rural parts of the country, there's not a lot of treatment available, be it a residential treatment facility or an outpatient treatment facility. And when we look at improving access to medication, So therapy for substance use disorder, in particular opioid use disorder, there's barriers that have been put in place, legal barriers from the federal government to prescribing, which we alluded to a few weeks ago with the data waiver for buprenorphine. But only a handful of physicians actually have it. And when we look nationally, we see that there's a 1 in 5 treatment gap where 1 out of every 5 people who needs help gets it. And to put it in perspective, what if 1 out of every 5 people who had a heart attack got help? When we put real numbers at it, there's 30 million people throughout the country with no access to care for substance use disorder. 30 million people, which is crazy. So while we have come a long way, certainly have, there's still a long way to go. And hey, if anybody down at Health and Human Services is listening, one, thank you for listening, and two, let pharmacists manage buprenorphine. Let's get rid of that data waiver and let's have pharmacists get involved. We could really do a lot to fill that gap.
Right, and I think it's amazing how we've only had 3 shows, and each show so far has tied into each other. So it's awesome how you're bringing that back into the conversation. But yeah, getting the treatment to people is something that pharmacists could do. Obviously, we're not allowed yet, or maybe we can be if they're those higher ups are listening. Thank you again, but it's good. We see patients every day, and we see these patients often, the same patients often. So we know how they feel rather than, I think it was, I don't know if it was you or a fellow colleague of yours, Dr. Pazina, who brought up how often people come back to the pharmacy versus their doctor. And we just see these reoccurring patients and we know how they feel. So if they are battling an issue like this, I feel like we could, be that next step to getting that treatment, which
and yeah, even when you look at where the population, where they are, we see that about 90% of the US population lives within 5 miles of a pharmacy. There are people in look at Pennsylvania as a great example. Most people think, well, there's Philly, there's Pittsburgh, and then there's a bunch of, space in between.
right.
In that space in between, there's a fair amount of people, but there's also a lot of primary care deserts, a lot of physician deserts where there are people but no one to take care of them. There are people who have to drive 2 hours to see their family doctor, but within their town there's a pharmacy. And we're not saying that pharmacists need to supplant physicians. We're not saying that pharmacists, are know-it-alls or anything. We're saying that we recognize a gap in treatment, a gap in the healthcare system, and how much money the healthcare system drains every year from our economy. And if pharmacists had the opportunity to assist in this endeavor, that could save literally billions of dollars to the healthcare system, increase access to care for millions of patients, and help ideally turn the life expectancy back in the right direction, because the last few years the life expectancy in the United States has gone down, and substance use is one of the 2 major causes of that. So you got to keep advocating and keep going, and knowing our policymakers, and policymakers may not be aware as to what pharmacists can do. So that's on us. That's something we need to do. So if you're a pharmacist out there and you're listening, or you're a student and you're listening, be sure to get out there and be the squeaky wheel, professionally, of course, to your local legislator.
Right, which ties into the third. I'm going to skip the second one quick, but the third point that HHS brings up is strengthening and understanding of the epidemic through better public health surveillance, which is something that you basically summed up in your last couple words there. I mean, being the quote unquote squeaky wheel in a professional manner goes a long way, especially with something that's this big of an issue.
And we also need to look at who's being impacted and how. And it's not just the people using the drugs or using alcohol or gambling or whatnot. It's all the secondary and tertiary things. What's the ripple effect that this could have on things such as the strength of neighborhoods? Perceptions of neighborhoods will drive property values. Property values go down and people want to move out. And then is that going to impact, the ability of families to generate wealth. We don't know. These are things that need to be explored. So when we say we're understanding it, there's the human costs in terms of people dying, and then there's all of the secondary financial and socioeconomic and mental health and infrastructure costs that come with it. So there's much more to this than just the drug side. And I mean, none of us are politicians. We are not policymakers. We're pharmacists, and we're also key members of our communities. And as doing so, we should also be advocating for our communities to be improved, and for the lives of our community members to be improved too. So those are the things that, if you ever get the opportunity, and you don't have to donate, money or anything, just go and talk to your local policymaker. That's kind of why they're there. Go and talk to them about not just the human cost, but all those other ancillary things that are associated with it.
Right, which, thank you for bringing light to that, because I feel a lot of the perception of pharmacists in a community setting is counting pills and, answering telephones, which, may be a majority of a pharmacist's day in the community setting, but there's a lot of stuff that goes on that a lot of people don't see. So people are always concerned about, why is the wait so long? But it's because that pharmacist, him or her, is taking their time to make sure that this is appropriate medication for you, if it's a new medication, and, that you're tolerating it well. Um, and that advocacy part is also huge. You don't see, pharmacists on the news often, like with signs protesting in front of Capitol Hill or in front of Harrisburg, like we need this or we need that. But they are there talking to their legislators, and they are there trying to make it better for, those who need it, and just overall better community, because that's what we want to do. We make our communities healthy, and, little by little, we're going to make the world a healthier place.
That
Yeah,
put it the world a healthier place. Well, if there ever was a time for that,
right. I
now
mean,
with a pandemic, and pharmacists absolutely are the ones who went headfirst, into COVID and the vaccine effort. They were the ones who were going out into at-risk communities, making it happen. So, we want to really give credit to the community pharmacists. And what's great, especially in communities that are at risk, or communities, that might be socioeconomically disadvantaged, the pharmacy is a social gathering place. The pharmacist is someone that the individual community members trust. And if they can leverage that trust to, right now, give COVID vaccines, but also to, ideally in time, start a public health life-sustaining medication such as buprenorphine, if there's trust that exists, people might be more willing to confide in their pharmacist about the fact that they know someone who has a substance use problem, and they want to get help, and that's the only healthcare provider around that they trust. So let's leverage it and use that as an opportunity to get more people living better lives and living healthier lives.
agreed. I think that's a great point. A lot of people come into the community pharmacy, as I mentioned. I see the same person in my community pharmacy 3, 4 times a week. Sometimes we have a daily conversation. But yeah, I mean, that trust is there, and we should definitely take advantage of it. The last 2 points I guess we could bring up from HHS that I mentioned previously were providing support for the cutting edge research on pain and addiction, and advancing better practices. So I think they tie in kind of nicely. But yeah, so far, I mean, we are educated in school on the naloxone use, specifically through your class, which is a good experience so far. I haven't heard anything bad.
Oh, no one likes to suck up. So.
I'm just saying, I haven't heard it in my ears. Maybe there's chatter otherwise, but I mean, your research for naloxone use, hopefully it brings good results. And we also have the advancing better practices. So if your study holds up well, hopefully you set that standard like you keep talking about. So, but I mean, I know there's plenty of other ways. I can't think of any right now, but
There's of course the research that people are doing, but then there's the research into more of understanding, effective treatment options. treatment, I think, is part of it, but it's also the funding. How can we ensure appropriate funding and support, not just for the patients and their families, but support for the providers? It can be a difficult, mentally challenging part of healthcare. So how can we ensure support for our people who are staffing? And then best practices for pain management. There's the CDC put out guidelines back in 2016, and then put out a revision statement on them in 2019 that focused on a holistic approach to pain management. That it's not just the medication. You can't just take meds and say, I'm good, that's it. There's so much more that needs to go involved with it. So it's also educating patients and educating providers to the fact that pain management is a team sport. And the more we can come together to bring our individual specialties together, the better outcome we're going to get for our patient.
Right. And you keep bringing up these good points. Like I can tie this into class this morning we had with Dr. Manning. We spoke with physical therapist students, and they were talking. One of the questions came up about how to manage chronic pain, regardless of medication. And they went in to say how managing their chronic pain is a holistic approach, a team approach. So it's not just the pharmacy educating the patient on their whatever their medication is that they're taking, but it also comes from the doctor how to properly take the medication. It comes from physical therapists giving them exercises and other workouts to stay healthy and stay on top of their game. So I like how you said that it's a holistic approach, and how it's not just the pharmacist's duty to say, hey, this is how you should be taking it and don't ask any questions. So it's a more holistic approach, very personable approach from the pharmacy, but then there's the other health professions that tie into this. But also tying in go ahead.
Well, I was going to say, I think what's great is that here's where your community pharmacy can come in again, is that because of the access, pharmacists are the most accessible healthcare provider. So because of that access, there's a great opportunity to coordinate care. Pharmacists will know, well, who are the physical therapists in the area? Who are the counselors in the area? Who are the physicians in the area? And be able to communicate with them, help patients get into them for purposes here of chronic pain. Because when we look at the data, there are some people, I of course will stand by. There are some people who are going to need to be on, an opioid pain medication for the rest of their lives. That's just the facts. But when we look at the totality of the data, we see that for most individuals, that long-term use of just pain medicine doesn't get you any better. And that the best thing you could do for chronic pain long-term is physical exercise and strengthening exercises to try to get your musculature kind of back in the swing of things. So there's plenty of opportunity to coordinate care, but it's also on the patients. We need to make sure that we are provided with time. We collectively as a healthcare institution are provided with time to properly educate patients about the overall goal of chronic pain treatment, and then to be properly compensated for the time that we put in. So I think that's there we are with trying to change the system again, trying to get things properly compensated for time and service rendered, which is a big notion of payment reform for pharmacy practice right now. So that's something that I think we can continue once again to advocate for, because we know it's in the best interest of patients. We know it's in the best interest of patient care. It's going to reduce harm. It's going to improve outcomes, and that's ultimately what we are all here to do.
Agreed. I think I said it. I don't know if it was last show or the first show, but pharmacist first thing in when you take the oath is do no harm, or first or second. I'm not sure. I don't remember. It was quite some time ago. P1 year. One figured, but yeah, like I said, do no harm, and it's a great point that you bring up with the CDC. I think it was, what do you say, 2016 was when they came up with this grouping approach. So from what I found about that is they referred to it as the overdose data to action, is it OD2A, and they funded 47 states. I don't have them all listed, and 2 territories to combat and survey the opioid crisis. In their efforts, they included tracking of non-fatal and fatal drug overdoses. They wanted to improve toxicology to better track the polysubstance involved deaths. and there's a couple other things they did that we already mentioned. So, and partnering with public safety is kind of huge because that ties into what GenRx is all about. So, we have the opioid awareness walk here on campus. Unfortunately, due to COVID, we haven't had it last year or this year, but that was a great time where we partnered with the Wilkes-Barre Fire Department, and we had a great showing from a lot of the athletic teams here on campus at Wilkes, and just a lot of people coming by, walking through campus would even participate in the mile walk, and it was a good opportunity for us to raise money to buy naloxone and to help fund or help combat the issue that the fire department sees here locally in Wilkes-Barre. So far, speaking on partnering with public safety and those issues, firsthand experience, I thought the CDC overlook has been good. But I'm not sure about monitoring trends to help understand and respond to the epidemic has gone in a positive slope from COVID.
Well, there's the key is
Right.
from COVID. So back in 2018. So in 2018 was the first time that we actually saw overdose death rates nationally decrease. It was the first time in a long time that it happened. And we saw it go down again in 19, and then poof, COVID hit. And even with the most recent data that we have currently available, looks at, I want to say it's either June or August of 19 through 20. So not even looking at the totality of COVID, just looking at maybe the first few months of it. So looking March to June or March to August, so you're thinking the time when many of the lockdown happens, the economic crash occurred, the first 1 to 2 surges of death happened and infection happened. And there was just coupled that with a ton of fear, uncertainty, unrest, and so much else going on that we saw just in that time period. So that calendar year, 81,000 people nationally died from a drug-related overdose. So one can only think, what is it going to look like when we get the data from March of 2020 to March of 2021, that which has just ended. How is that going to look? And how will we compare, say, March of 2019 to March of 2020 against it? And that will be our tell. What did 1 year of COVID really do in terms of substance use related deaths? And it's still with us, unfortunately. We're doing everything we can to overcome it. But what's it going to do for it going forward?
Right. Unfortunately, I don't think that would be a good number to look at for research purposes. I think it would be interesting to see, but hopefully it's not that big of a change. And, during COVID, hopefully we stayed on track as our goal in GenRx and those in office have brought light to this issue. But, with that staggering number of 81,000 deaths, it's a tough number to swallow, especially since we were doing okay, and then unfortunately this pandemic happened, and we lost some lives. But I think from one thing that we could speak on with increasing public awareness about the prescription opioid misuse and overdose to make safe choices in opioids is something that you and I and Harrison and Dylan, I can only speak on them so far, but in the past of Generation RX have done a pretty excellent job on, because despite the pandemic we weren't out and about, but we were able to reach with a partner in the Luzerne Medical Society, um, local pharmacies with pamphlets on proper medication disposal. And that was always something that we did in the past in person. We had volunteer students, and I believe you were there at Take Back Days, and I specifically one at the courthouse. I'm not sure of other locations, but that's something that we have done and brought light to, which I thought has been a tremendous effort. And with the pamphlet now adjusting to COVID, I think we sent it to about 10 or 15 different local pharmacies, which, thank you to those pharmacies for letting us send you that flyer. But yeah, I'm not sure about how we still stand on that.
Well, I mean, it goes to show that, at least on our local level, that the relationships that folks like Dylan and Harrison and now yourself have made with strategic partners in the community. So the County Medical Society, the fire department, and so many others, how those have endured during a time where we're at home now. We're not in a shared space. We're each in our own offices recording this. How we're able to still be able to have some semblance of community outreach and education, really focusing in on educating the pharmacists out there now, our local pharmacists, about things such as naloxone and naloxone availability, drug take back, things along that line. And hey, we heard it. It's been on the news. They're saying July 4th is going to be the powers that be say July 4th should be one of our first semi-normal looking holidays. So you never know. Maybe we hit the fall and we might be in a place, and there's an opportunity for us to get more involved and really kind of get back boots on the ground in the community, doing our thing. But I'm happy that we've been able to maintain those relationships. I feel like we've also been able to strengthen them. Thank you, Zoom, for that and getting us, semi face to face. So there were still some positives that came out of this, despite the significant amount of negative associated with the last year.
Right. But yeah, we're getting vaccines in the arm, and it was crazy, thinking that, people are saying, oh, we'll be vaccinated by April. And it's like, that was crazy thought. And now it's happening. We're getting vaccines in the arm, and July 4th, hopefully that's a good date and we can have those safe gatherings. And that will be just another step for us to take to reach the community in a safe environment and, host a walk with, social distancing and proper guidelines. So thank you to those who are taking that action and working the front lines. Thank you for your service. And it just shows that, not only do we need money to fund the issue and support those who are going through this tough time combating COVID, and on top of their, the opioid epidemic, because I feel like, yes, COVID is super important, but we also underlook the issue that's been going on of the opioid epidemic. Through Generation RX, like I keep mentioning, we have done some great things, and it's going to be important to keep educating people in the community about us locally, and other colleges that have Generation RX to spread the word as well, so we can, build a healthier nation and educate those people on the epidemic as a whole and how we have come from, the toxic, possibly unethical marketing, and how we have brought up these new drugs that are life-saving, and how we have now, I want to say, what's the word I'm looking for? The proper nomenclature for how to describe people if they're, they're having a bad reaction to one of these medications.
Right, and I think that has been some of the great steps that HHS and the Office of National Drug Control Policy have come out with, were the appropriate language, trying to destigmatize how people would refer to individuals, how to use a person first language, which is fantastic to help take away some of the shame that is associated with addiction. And yeah, trying to push more education. There's new education guidelines that got published in November for pharmacy students relative to substance use disorder. So there's all sorts of new stuff coming out. And of course, I'd be remiss if we did not use this as a shameless plug for the third annual Pennsylvania Pain and Addiction Summit coming up on April 23rd. We're going virtual this year. All the speakers from last year are coming back, including TV's Dr. Drew from, I think he was on like Celebrity Rehab and whatnot. So or the host of it. He is our keynote speaker. So we have some great programming coming up. So if you're listening and you want a bunch of continuing education credit for your license, it doesn't matter, physician, nurse, pharmacy, social work, lawyer, you name it, we got it. Check out Pennsylvania Pain Addiction Summit on Wilkes's website, and it's going to be a really great time this year. Keeping it virtual.
Right. I think last year it was canceled, correct? Last year.
Yeah, last year we were like 2 weeks out, and boom, we got hit with the lockdown.
Right.
So just kindly, everybody, including Dr. Drew, agreed to stay with us for the year and are able to present virtually on the 23rd. So that's great. We do, fingers crossed, hopefully we'll be able to go back to being live in April of 2022. But for now, we're hopeful for a great turnout. We already have a nice amount of folks signed up. So hopefully we get more people.
Yeah, and that's great. I'm actually looking forward. This is the first year I'll be able to participate and volunteer with, unfortunately, like you said, on the Zoom proctoring. But I look forward to the day, and I'm going to use it as a good learning experience, and look forward to the guest speakers and Dr. Drew, especially him, to see what they have to say. The last thing I just wanted to mention before we end the show was the PDMP, or the Prescription Drug Monitoring Program, and how, I don't know, do you think that this has helped combating this crisis, or has it not done too much, do you think?
Well, I think we need to look at why the prescription drug monitoring program, which pretty much every state has, by the way, it's not
Right.
just a Pennsylvania thing.
Mhm.
The genesis of it was a mechanism to track controlled substances that were filled in pharmacies. So it's like a repository where we are able to see who who filled it, when was it filled, who wrote for it, how was it paid for, how much of it was given. So we're able to track that. And the idea was we would find people with questionable fills on their record and use it as an opportunity to refer them into treatment. Unfortunately, and this has even been promoted by the government, that the PDMP is being used more as a cudgel or to beat people with. To, oh, we found an error, get out of my pharmacy, get out of my store, and it's being used more as a trap program rather than an opportunity to help people. So, and it all comes back to, there's still a stigma with it, substance use, that is. And there, even us as pharmacists or physicians or anyone else who has access to the PDMP, they don't know where local treatment programs are, or how to get in contact with local treatment, how to have the conversation with a patient about it. So doing things like SBIRT, or screening, brief intervention, referral to treatment, is something that many people are not familiar with. So while the PDMP, good in theory, questionable in its execution, yes, prescriptions for opioids have gone down, rates of doctor and pharmacy shopping have gone down, but are we seeing more people get into treatment, or are we seeing it result in more people just getting kicked to the curb? And I think that the fact that the government came out and said we don't want it to be used as a way to get rid of people, we want to use it as a way to help people, is something that we need to turn around. And if there's another opportunity to advocate, hey, Harrisburg or DC, you want us to have more, you want us to help more folks with the PDMP? Let's have some payment reform so we can get paid for the services and the time we provide in counseling them based on what the PDMP told us. And then we'll have an opportunity to help more people. So it all comes back here. Here we are, full circle at advocacy, to really make sure we go and educate our policymakers as to, if the system changed in the way we all know it can, the way in which the public wants it changed, that there will be better outcomes, and all the tools we were given we could use to the fullest extent, and we'll have a healthier population for it.
Right. I've had firsthand experience using the PDMP, and in a theory, yes, it's a good idea. It's a good tool to use. It's pretty neat concept, but right, the stigma behind it, sometimes, we do kick people to the curb, and it's something that, like you said, we need to investigate more, and feel maybe those purchasing, or not purchasing, the reimbursement for our services that we provide, it would shed a more positive light through the PDMP. So thank you for your comment on that. I don't think I have anything else that we want to talk about this week, but we can sneak preview our show 2 weeks from now on the Lock Zone, which is kind of like the summary, the be all of combating the crisis. So I'll tease it a little bit now. We won't go too much into it. So I would just want to thank you again for your time for this 30. This one was approximately 30 minutes, not as long as the last show, as we promised. But thank you again, Dr. Franco, for your time. I really appreciate your professional input on everything. Another good conversation about the opioid crisis. Please tell your friends and tell your family about the show. We've been getting more views bi-weekly, so keep sharing it. You know, the show's always up there, so press that subscribe button. Even just run it on the background to run up the likes or run up the plays. We would appreciate it. And the comment section is always open, so anything positive, try to refrain from the negatives. But you know, if there's anything you want to bring to us, our attention, please comment below or shoot us an email. So on behalf of me and Dr. Franco, I want to say enjoy the rest of your weekend and tune in 2 weeks when we talk about naloxone. Thank you, guys.